Everybody, this is Dr. Nadeem. We are with Neelam Path Lectures, the Pursue series. All our lectures are available on YouTube. We have a Telegram group for accessing lecture related information. You can join that group. We have a Google Drive where the PDF of all lectures are available. These are the disclaimers. And we are with phase 3, which is recorded pathology lectures. And today we have Pursue 26E, which is spongiotic dermatitis, and we are streaming from Medical College, Solan, Himachal Pradesh. To talk on today's topic, we have Dr. Mehak Kashyap Nijhawan, who has done her MBBS from Indira Gandhi Medical College, Shimla, her MD from Maharishi Markandeshwar Medical College and Hospital, Solan. She is a senior resident in the same college. Her areas of interest is hematopathology, dermatopathology, and gynecopathology. She's got 8 publications in international and national journals. So I'd request Dr. Mehak to start her lecture on spongiotic dermatitis. Over to you.
Hello everyone. The topic for today's discussion is spongiotic dermatitis. These are some common dermatology terms which will be used frequently in this lecture. First is macule. It is a circumscribed area of change in skin color without elevation or depression. Then plaque. Plaque is a plateau-like elevation above the skin surface. It occupies a relatively large surface area in comparison with its height above the skin. Papule. These are superficial elevated solid lesions measuring less than 0.5 cm in diameter. And a nodule. It is a palpable, solid, round or ellipsoidal lesion which is larger than a papule. That is, it measures more than 0.5 cm in diameter. It may involve the epidermis, dermis or subcutaneous tissue. Now coming to today's topic. So what is spongiosis? Now this is normal skin and this is spongiosis. As we can see here, in normal skin, the squamous cells are tightly packed together. Whereas in spongiosis, there is fluid which pushes the squamous cells apart. The fluid can accumulate in small blisters. These blisters are known as microvesicles. Now this is how we see spongiosis in histopathology sections. So, by definition, spongiosis is the accumulation of edema fluid between keratinocytes, in some cases progressive to vesicle or even bulla formation. It is of 3 types: acute, subacute and chronic. Clinically is known as eczema, which means to boil. It is characterized by itching and soreness. This picture is showing acute eczema with erythema and marked exudation. And this is a picture of chronic eczema of the arm showing lichenification, that is leathery and thickened skin along with fissuring and scaling. Now starting with the first type of spongiotic dermatitis, that is acute spongiotic dermatitis. In acute spongiotic dermatitis, stratum corneum is normal and epidermis is of normal thickness. Spongiosis can vary from slight to marked and there is formation of intraepidermal vesiculation when spongiosis is marked. The surrounding keratinocytes may be stellate, surrounded by clear spaces representing the site of fluid collection. There is papillary dermal edema and a lymphohistiocytic infiltrate is present around the superficial plexus with exocytosis of lymphocytes into spongiotic foci. Now this is a picture of acute spongiotic dermatitis. Here we can see the normal thickness epidermis with spongiosis. Lymphocytes, histiocytes and eosinophilic infiltrate is present around the superficial plexus. And in this picture we can see the intraepidermal vesicle also. Second is subacute spongiotic dermatitis. It shows moderately acanthotic epidermis, parakeratotic stratum corneum, which may contain aggregates of coagulated plasma, scattered lymphocytes and neutrophils forming a crust. Spongiosis is usually mild to moderate. Occasionally there is formation of microvesicles. And there is presence of superficial perivascular lymphohistiocytic infiltrate, but it is less prominent than in the acute phase. Now this is a picture of subacute spongiotic dermatitis. we can see the acanthotic epidermis. There is parakeratosis and focal lymphocytic exocytosis. Another picture showing subacute spongiotic dermatitis. There is irregular acanthosis, spongiosis, superficial perivascular inflammatory infiltrate, parakeratosis containing plasma is also present. And in this picture we can see that spongiosis is also accompanied by exocytosis of inflammatory cells. Third type is chronic dermatitis. In this we see hyperkeratosis with areas of parakeratosis. There is wedge-shaped hypergranulosis, moderate to marked acanthosis, minimal spongiosis, sparse inflammatory infiltrate, papillary dermal fibrosis and vertical streaking of thick papillary dermal collagen. Now this is another picture showing vertical streaking of dermal collagen. This is the vertical streaking. Now this table is a comparison of the histology of the three types of spongiotic dermatitis. As discussed, in acute spongiotic dermatitis, stratum corneum is normal. In subacute, there is parakeratosis with crust formation, and in chronic, there is hyperkeratosis and parakeratosis. The epidermis is of normal thickness in acute, whereas it is moderately acanthotic in subacute, and chronic shows wedge-shaped hypergranulosis along with moderate to marked acanthosis. Spongiosis is slight to marked in acute, mild to moderate in subacute, and minimal in chronic. Inflammatory infiltrate consists of lymphocytes and histiocytes and is around the superficial plexus in both acute and subacute, whereas in chronic, the inflammatory infiltrate is sparse. One more additional feature of acute is lymphocytic exocytosis into spongiotic foci. And of chronic, there is vertical streaking of dermal collagen in chronic dermatitis. Now here are the pictures. We can see acute spongiotic dermatitis with intraepidermal vesiculation. In subacute, we can see moderately acanthotic epidermis. There is parakeratosis and crust formation, whereas in chronic, we see hyperkeratosis, parakeratosis, wedge-shaped hypergranulosis, marked acanthosis, but sparse inflammation. Also, we see papillary dermal fibrosis. Now, what are the different types of spongiotic dermatitis? These are atopic dermatitis, allergic contact dermatitis, irritant contact dermatitis, dyshidrotic dermatitis, photoallergic dermatitis, nummular dermatitis, seborrheic dermatitis, statitis dermatitis, papillary dermatitis, and lichen simplex chronicus. Starting with the atopic dermatitis. Most patients are diagnosed in childhood and it is characterized by severe pruritus, erythema, scaling and excoriation with chronicity, lichenification and lichen simplex chronicus. Also, there is increased incidence of contact dermatitis noted among patients with atopic dermatitis. Now, we can see in infants the lesions predominate on the face and extensor surface of the extremities, but later they affect the flexural surfaces. Now this is infantile puffy face with confluent erythema, papules, microvesiculation, scaling and crusting. Classically involved sites in older children and adults are popliteal and antecubital fossa and the sides of the neck. Now, one of the hallmark of atopic dermatitis is lichenification in the flexural region as shown in this picture. We can see the thickening of the skin with exaggerated skin lines and erosions. Now, histopathology of atopic dermatitis. In early phases, we see parakeratosis, mild spongiosis and exocytosis of lymphocytes and lymphohistiocytic infiltrate present around the superficial plexus. Whereas long-standing lesions show hyperkeratosis, parakeratosis, wedge-shaped hypergranulosis with elongation of rete ridges. As we have seen earlier, there is less prominent spongiosis and cellular infiltrate, and eosinophils are less conspicuous in the long-standing lesions. Now, this is a picture of atopic dermatitis showing superficial perivascular infiltrate and exocytosis of lymphocytes. Now second type is allergic contact dermatitis. It is caused by re-exposure to a substance to which the individual has been sensitized. It is known as phytodermatitis when it occurs secondary to exposure to poison ivy. Its other common causes include nickel, paraphenyldiamine, rubber compounds, fragrances, and preservatives in cosmetics. It usually occurs between 24 and 72 hours after exposure to the antigen. First is acute allergic contact dermatitis. In this, we see well-demarcated erythema and edema with superimposed closely spaced papules or non-umbilicated vesicles. In severe reactions, bullae confluent erosions exuding serum and crust can be seen. Now this is a picture of acute allergic contact dermatitis. This is on the lips and is caused by lipstick. We can see the bright erythema and microvesiculation. This occurs secondary to nickel in the jewelry. Now second type is subacute allergic contact dermatitis. In this mainly we see plaques, but sometimes rounded erythematous firm papules and scales can also be seen. Now this is a picture of subacute allergic contact dermatitis resulting from nickel. Here we can see a mixture of papillary, vesicular and crusted lesions. Also, there is a loss of sharp margination. This patient was a watchmaker. He used a metal clasp on the dorsum of the left hand while repairing watches. He was allergic to nickel. Third is chronic allergic contact dermatitis. In this, we'll see plaques of lichenification, that is the thickening of epidermis with deepening of skin lines in parallel or rhomboidal pattern. They can be scaling with small, firm, rounded or flat-topped papules, excoriations and pigmentation. This picture, this is chronic allergic contact dermatitis because of PlayStation controller. Now, allergic phytodermatitis, which occurs due to poison ivy. In this, initially we see well-demarcated patches of erythema, characteristic linear lesions. Then followed by papules and edematous plaque, microvesiculation and later vesicles and even bulla formation, which can erode or show crust formation. In this first picture, we see linear vesicular lesions with erythema and also we can see the edema on the calf. This is at the site of direct contact to the skin, which occurred 5 days after exposure to the poison ivy leaves. In this second picture, we can see erythema, edema and microvesiculation in the periorbital and perioral area. This is in a previously sensitized individual. Now, the histopathology of allergic contact dermatitis. Early lesions are acute spongiotic dermatitis. If vesicles develop, they may contain clusters of Langerhans cells. Superficial dermal infiltrate of lymphocyte, macrophages and Langerhans cells with accentuation around the small vessels. Eosinophils may be present in the dermal infiltrate as well as within areas of spongiosis. With continued exposure, the biopsy may show a subacute or later a chronic spongiotic dermatitis, often with lichen simplex chronicus. Now third type is irritant contact dermatitis. As the name indicates, it occurs after exposure to an irritant. It can be of acute and chronic type. In acute, clinically we see scaling, redness, vesicles, pustules or erosions. And it is caused by mild irritants such as detergents, water with additives, adhesive tapes and cosmetics. Whereas chronic is characterized by dryness, chapping and there is absence of vesicles. It is caused by repetitive contact to water, detergent and solvents. Now this picture shows irritant contact dermatitis which occurred following application of a cream for backache. We can see the massive erythema. There is also blister formation. And this contact dermatitis resulted from an industrial solvent. In this we can see massive blistering on the palm. This is a picture of chronic irritant contact dermatitis. Early chronic irritant contact dermatitis. This is in a lady and this has resulted from repeated exposure to soaps and detergents. We can notice the glistening fingertips. It is called as pulpitis. And this is irritant contact dermatitis in a construction worker who works with cement. We can see the hyperkeratosis, scaling, fissuring, and there is minimal pustulation in this. Also, we notice that the right hand, which is the dominant working hand, is more severely affected than the left hand. Now, histopathology of irritant contact dermatitis. It is similar to allergic contact dermatitis, but no or very rare eosinophils. The cases may show superficial epidermal necrosis, intraepithelial neutrophils, and crust formation. Now, this picture shows superficial epidermal necrosis, spongiosis, and infiltrate of neutrophils. Crust formation is seen in this. Now, next type is dyshidrotic dermatitis. It is characterized by recurrent, severely pruritic, deep-seated vesicles. It classically involves the lateral aspects of the fingers. Episodes may be precipitated by infections, contact reactions, and emotional stress. In chronic cases, there may be more extensive involvement of the palms and soles. Now, this is a picture of dyshidrotic dermatitis. In this, we can see the pruritic vesicles on the lateral fingers. Now, in contrast to spongiotic vesicles at other sites, in dyshidrosis, they often remain intact. Now, histopathology of dyshidrotic dermatitis. Spongiosis and intraepidermal vesiculation occur in acute lesions. There is a superficial perivascular lymphohistiocytic infiltrate with exocytosis of lymphocytes into the spongiotic zones. The infiltration is usually mild. In acute lesions, the compact thickened stratum corneum, it remains intact and the epidermal thickness is normal. With chronicity, the spongiosis diminishes, acanthosis and parakeratosis predominate with variable crusting. Now, a periodic acid skips, that is, PAS stain, should always be performed on vesicular lesions of the palms and soles. This is because tinea manis or pedis may mimic dyshidrotic dermatitis histologically. Now, next we have photoallergic dermatitis. Now, what is photoallergy? It is the increased reactivity of skin to ultraviolet and visible light and is brought about by a chemical agent on an immunological basis. Its types are photocontact dermatitis, photodrug eruption, and phototoxic reactions also come under this. Now, photocontact dermatitis, it occurs due to topical application of a photosensitizing agent, soaps and cleanser containing halogenated salicylic anilide, perfumes, topical sulfonamides, sunscreens, and benzocaine. The common causes of photodrug eruption include thiazide diuretics, oral hypoglycemics, and phenothiazines. Phototoxic reactions are sunburn reactions. Now, these are the pictures of photoallergic dermatitis. The eruption is pruritic and composed of erythematous papules and confluent plaques on the sun-exposed skin, usually the face, the neck, and the dorsal aspect of the arm. In second picture, we can also notice that there is sharp demarcation between the sun-exposed and sun-protected areas. Now, histopathology of photoallergic dermatitis. Its features are similar to that of an acute allergic contact dermatitis, that is, variable spongiosis, vesiculation, and superficial perivascular lymphohistiocytic infiltrate with exocytosis. In photoallergic dermatitis induced by drugs ingestion, there will be deeper perivascular infiltrate and eosinophils will be more common. In chronic exposure cases, there will be acanthosis, mild spongiosis, and less intense inflammation. Histopathology of phototoxic reaction. In them, there is formation of intraepidermal to subepidermal blisters, epidermal apoptosis and necrosis, and neutrophils may be prominent. Next type of spongiotic dermatitis is nummular dermatitis, which is characterized by pruritic, coin-shaped, erythematous, scaly, crusted plaques. It mainly is seen on the extensor surface of the extremities. And nummular dermatitis is the prototype of subacute spongiotic dermatitis. Next type is seborrheic dermatitis. It is characterized by erythematous and greasy scales on the scalp, ears, eyebrows, nasolabial areas and central chest. In infants, the scalp, cradle cap, face and diaper areas are often involved. This is known as cradle cap. Now, histopathology of seborrheic dermatitis. The histopathological features are a combination of those observed in psoriasis and spongiotic dermatitis. The stratum corneum contains focal parakeratosis with a predilection for the follicular ostia, and this is known as shoulder parakeratosis. Occasionally pycnotic neutrophils, they are present within the parakeratotic foci. Then it is known as neutrophilic parakeratosis, and sometimes with fluid, which is known as neutrophilic crust. There is moderate acanthosis with regular elongation of the rete ridges, mild spongiosis and focal exocytosis of lymphocytes. Dermis contains sparse mononuclear cell infiltrate. Now, in this we can see the hyperplastic epidermis, neutrophilic parakeratosis on the follicular ostia, which is known as shoulder parakeratosis, and we can see the spongiosis is minimal. Next type is stasis dermatitis. It occurs due to chronic venous insufficiency or stasis. In this we see pruritic, erythematous, scaly papules and plaques on the lower legs, often in association with brown pigmentation and hair loss. Its frequent complication is ulceration. In this we can see the erythematous, scaly papules and plaques on the lower legs. Also we see the brown pigmentation and hair loss. Here there are two coalescing ulcers with the necrotic base. Now, histopathology of stasis dermatitis. In this, the epidermis will be variable, may be hypertrophic with focal parakeratosis, acanthotic to atrophic and with focal spongiosis. Superficial perivascular lymphocytic infiltrate surrounds the thickened capillaries and venules. There is proliferation of small blood vessels in the papillary dermis forming lobular aggregates, which is known as glomeruloid proliferation. These are the glomeruloid proliferation. Reticular dermis, as we can see, is often fibrotic. Extravasated erythrocytes and hemosiderin-laden macrophages can be seen. Fibrin thrombi may be observed. Endothelial necrosis and neutrophils may be present. Next type is papular dermatitis. Now, this is a recently coined term to describe the refractory pruritic papules of unknown etiology. It is also known as itchy red bump disease. Common sites include trunk, pelvis and proximal extremities. Now, this picture shows numerous edematous red papules with variable crusting. Crusting is often caused by excoriation. Now, this picture shows the histopathology of papular dermatitis. This is the scanning magnification. In this we can see the superficial and mid perivascular and interstitial lymphocytes, whereas these two are the closer inspection. They reveal focal spongiosis, and in this we can see dermal eosinophils. Now the last type is lichen simplex chronicus. Lichen simplex chronicus is characterized by focal thickening, hyperpigmentation and lichenification. This occurs secondary to chronic rubbing. These are mainly localized or solitary lesions, occur more often in the setting of chronic spongiotic dermatitis, particularly atopic dermatitis. Its histopathology shows compact orthokeratosis, variable parakeratosis, psoriasiform hyperplasia, hypergranulosis, papillary dermal fibrosis, vertically oriented blood vessels within papillary dermal tips and residual spongiosis. Now, in this picture we can see the vertically oriented blood vessels within the papillary dermal tips. Now, what are the differential diagnoses of spongiotic dermatitis? So, differential diagnosis of acute spongiotic dermatitis are pityriasis rosea, gutted parasoriasis, spongiotic drug eruptions, arthropod bite reactions, and dermatophyte infections. Pityriasis rosea, it starts with the Herald patch followed by a disseminated eruption. The lesions are found chiefly on the trunk, neck, and proximal extremities. These are round to oval salmon-colored patches following the lines of cleavage, and they show peripherally attached thin cigarette paper-like scales. Their histopathology shows mounds of parakeratosis, discontiguous suprapapillary areas of spongiosis, exocytosis of lymphocytes, and extravasated erythrocytes in the involved papillae and overlying epidermis. Here we can see the mounds of parakeratosis. There is psoriasiform hyperplasia, spongiosis and mild lymphocytic exocytosis is seen. Superficial perivascular lymphocytic infiltrate along with red cell extravasation is also seen. Next differential is gutted parasoriasis. Its histopathology is similar to pityriasis rosea but lacks the intraepidermal erythrocytes and it has less lymphohistiocytic infiltrate. Next is spongiotic drug eruption. It tends to have a deeper infiltrate with eosinophils as discussed earlier than other forms of acute spongiotic dermatitis. It usually do not vesiculate. Next differential is arthropod bite reaction. Now most things are evoked by mosquitoes, bees, wasps, hornets or bedbugs. These are characterized initially by a localized urticarial reaction, often followed by the development of a papule and papulovesicle associated with intense pruritus. In more intense reactions, the lesions are bullous. Now, in these pictures shows papillary urticaria. Now, this is a young male with multiple erythematous papules on the exposed face and neck. Now, his bedding was heavily colonized with bed bugs. Now, this is papillary urticaria in a young girl with multiple mosquito bites on face. Now, histopathology of arthropod bite reaction. In this, the epidermis shows spongiosis, necrosis, ulceration, and sometimes retained arthropod parts within the overlying epidermis. Dermis shows wedge-shaped, superficial and deep, perivascular and interstitial inflammatory infiltrate, which is composed of lymphocytes and eosinophils. And eosinophils may be numerous in arthropod bite reaction. Neutrophils are more prominent in bite reactions of fleas, mosquitoes, and fire ants. Now, here we can see the wedge-shaped perivascular inflammation in the superficial dermis consisting of lymphocytes and eosinophils. In these pictures, we can see the prominent eosinophils and also a portion of arthropod is retained in the tissue specimen. Now, the differential diagnosis of subacute spongiotic dermatitis. These include pityriasis lichenoides, dermatophyte infection, spongiotic drug eruption, and arthropod bite reaction. First, pityriasis lichenoides et varioliformis acuta, that is pleva. In this, the lesions are sharply circumscribed, apoptotic keratinocytes are seen, dry neutrophil-rich scale, band-like interface dermatitis. Then there are areas of epidermal necrosis and deeper perivascular infiltrate is seen. Next differential is dermatophyte infections. They characteristically have neutrophils within the stratum corneum. Past positive fungal hyphae are seen. Last, the differential diagnosis of chronic dermatitis. They include pellagra and other nutritional deficiencies, mycosis fungoides, and psoriasis. So first, pellagra. What is pellagra? It is the deficiency of vitamin B3, that is niacin. In this, epidermis shows psoriasiform hyperplasia with hyperkeratosis, parakeratosis, scattered necrotic keratinocytes, granular cell layer loss, and architectural disarray with desmaturation of the epidermis. There is depigmentation of the basal layer with accumulation of fat droplets. Dermis shows lymphocytic perivascular inflammatory cell infiltrate. There is fragmentation, swelling and thickening of elastic and collagen fibers. Second differential is mycosis fungoides. In this, there will be variable epidermal changes. Atrophy and or psoriasiform hyperplasia is seen. Band-like lymphocytic infiltrate with epidermotropism. Lymphocytic atypia is seen, that is hyperchromatic cerebriform nuclei with perinuclear halos. Also, there is viriddermal collagen. In this picture, we can see psoriasiform hyperplasia with atypical epidermotropic lymphocytes. And this is hyper view of the same. Next is psoriasis. In this, the epidermis shows hyperkeratosis and parakeratosis, neutrophils within the stratum corneum and upper epidermis, thinning of the suprapapillary plates, and dilated tortuous capillaries. Now this is a picture of well-developed plaque of psoriasis. Here we can see acanthosis with club-shaped rete ridges of even length, thin suprapapillary plates, absent granular layer, confluent parakeratosis with collection of neutrophils. Now a few words about Incontinentia pigmenti. It is an X-linked inherited disorder which occurs at birth or infancy and is typically seen in females. Clinically, the lesions are typically displaced in swirl patterns and linear arrays on the trunk and extremities. Extracutaneous manifestations include ocular, dental and CNS abnormalities. Now its rash has three stages: acute vesicular or urticarial, chronic verrucous and chronic pigmented. First stage, that is acute vesicular or urticarial, it shows spongiosis, so we will be talking about it. Now the acute or vesicular stage, in this we see eosinophilic spongiosis with intraepidermal vesicles and microabscesses. Dyskeratotic keratinocytes are often present and the dermis shows variable pigment incontinence. This is the picture of histopathology of first stage of Incontinentia pigmenti. In this we can see microvesicles within the epidermis. Second picture shows eosinophilic spongiosis and this is a high power view of the same. Now this is a comparison of the histological features of different types of spongiotic dermatitis. As we can see, the superficial perivascular lymphocytes, they are present in all, whereas deep perivascular lymphocyte, it is seen only in papillodermatitis. Epidermal necrosis is seen in irritant contact dermatitis and may or may not be seen in papillodermatitis. Now, follicular spongiosis is characteristic in seborrheic dermatitis and may be seen in papillodermatitis and atopic dermatitis as well. Dermal eosinophils are present in all except pityriasis rosea but are characteristic in papillodermatitis. Lymphocyte exocytosis may or may not be present in all the stages, but it is increased very much in pityriasis rosea. Erythrocyte extravasation, it is not seen in any of the spongiotic dermatitis except pityriasis rosea, that is only pityriasis rosea, in that we see RBC extravasation. These are my references. Thank you.